right, how's everybody doing today? It is nice to see so many people here. It's so nice outside, and to be here with us this afternoon, it's just wonderful to see all of you. So I'm here, I modified the presentation a little bit, and I will stay after to answer any questions for the panel. So if you have questions, you can hang tight, and I'll be around at the end of the session today to talk about it. So what I talked about was multiple sclerosis and how does it impact our bowel and our bladder, and is there anything conservatively that we can do? And as a pelvic floor physical therapist, there's a ton that we can do. So I'm going to give you a little bit of background about myself. So when I was 26, I was in a really bad car accident. I fractured my pelvis in places that your pelvis should never be fractured. I almost didn't think I was going to survive physical therapy school to even be here with all of you today. I could not sit down. I felt like I had to go to the bathroom all the time. And when I did go, nothing happened. And I was 26 years old and wearing pads, and I have not had a baby yet. It was really frustrating. There was no one in this area that could do anything to help me. My doctor pushed medicines. They didn't really help much. I tried lots of exercises with other therapies. It also didn't help much. So then finally I went to Cleveland Clinic, and I met a pelvic floor therapist. The urologist referred me immediately. And in an hour and a half, I learned more about my body as a female than I should have known all of my adolescent life. So I'm hopeful that today you get to take away some strategies as well as some resources to know that if you're having any symptoms of your bowel or bladder, which usually they're very typical, there are things that we can do, but it starts with talking about it. So I want to tell you about what I do, what is pelvic floor physical therapy, and how is it different from physical therapy that you may have had in the past or may have in the future. And then I just want to review a little bit about what's considered normal bowel and bladder function, and then what can happen with the MS pathology, and then what can we do about it. So by the end, we'll pull all that together. So what's our goal? This is our goal, right? This was a gift from a patient, and I'm telling you, we cheer for you. We have like poop dances. When you tell us you had a bowel movement, we are ecstatically happy. When you tell us you didn't wear a pad today, we will cheer for you and do that dance again, because this is what we are here to do. I almost wore this shirt today, but I was worried no one knew me and how it would look, so maybe next time. All right, so we're going to talk about a patient case to give you an example, and you may be able to relate to Kate. Kate is 66. I saw her from a referral from her neurology physical therapist. She has relapsing remitting multiple sclerosis. She had a flare about a month ago, lasted about 6 weeks, but she's complaining of leaking during her physical therapy sessions. So we want to delve into what is going on. An interesting part about Kate is as a child, she used to wet the bed a lot, and through adolescence, this occurred as well. And then she actually had to have a surgical procedure to make her urethra wider to open so that she could actually go to the restroom. This is not untypical of men or women who have MS having issues of your bowel and bladder, even pre-deceiving your diagnosis of MS. So what was going on with her? She lives with her spouse. She's using a cane to walk. She's leaking during intercourse, so what'd she do? She stopped. Just take it off the table. She also stopped going to PT because she was leaking during her sessions. You don't really want to have to go to the bathroom during your physical therapy session in the gym or risk leaking in front of a gym full of people. She was wearing 5 pads a day, and I know from personal experience that gets really expensive, and I would much rather spend my money on something more fun than Depends or pads. So she was leaking all day long, kind of like droplets that just keep adding and adding and adding, and by the end of the day, you're really, really damp. That's what was happening to her. And she was going to the bathroom about every hour, but even worse, she was going about 5 times at night as well. So she's not getting sleep, she's really fatigued during the day, and we're really frustrated at this point. Key point though, she didn't have that shirt. She was only having 1 to 2 bowel movements a week. And even when she did go, she was spending 30 minutes on the toilet to try to empty, and nothing was happening. Does this sound familiar to anybody? So what do I do exactly? If we kind of take Kate in a picture and she's telling someone all of this, what do you do? Who do you talk to about it, and what can be done? I can tell you in pelvic floor physical therapy, I want to know everything. I will talk to you for a half hour about your bowel habits, your bladder habits, and any sexual function or pain, because we need to dive into what is specifically going on to figure out what we can do to manage it. So you will leave the session knowing more about your body than you probably came in realizing you would learn. So we look at the muscle dysfunction of our gut, of our bowels, of our bladder. So if you take your chest, your belly, and your pelvis, and you think of everything that runs through, so you all just ate lunch, the food is moving down, we treat all the muscle dysfunction from your mouth to your anus, like the whole tube. And that's what makes this such a specialty, because not every PT will learn this coming out of school. This is a lot of education, a lot of training, years. I've been doing this 5.5 years, and I still wish I knew more. So we collaborate a lot with obstetricians and gynecologists and urologists, colorectal surgeons, gastroenterologists, neurologists. I mean, you name it, we're pretty much working with you, because your bowel and bladder impacts every part of your life and then how we live it. So what do we treat? This just kind of gives a little balance of things you may see in regards to what we treat. So urinary issues, you may be leaking urine. You may feel like you have to go all the time and not be able to make it to the restroom. You may be waking up at night. You may sit down and be really jealous of the person next to you in the stall because they just sit down and start and everything is amazing. And you're sitting there going, oh my gosh, I can't start. I'm spending so much time in the bathroom. Sometimes we work with urologists with people who want to wean off a catheter. Maybe you got started too soon. You're on a medicine. Things are helping you out. Is there a process that we can do to get you off catheterizations? Bowel issues, again, any incontinence or urgency or feeling like you're not going enough or things are just way too much work compared to how they used to be. And then pain. Pain is a big one. So I will see individuals with MS. You might bloat or feel pregnant by the end of the day. Your stomach could physically distend inches because your bowels aren't moving. You could have rectal pain that we don't know what's going on with it, abdominal pain, chest pain. You just have to kind of think anything from the mouth down, what's happening in there and the pain associated with it. So we do a very thorough history. I get to spend about an hour to an hour and a half with you. It's amazing. How many doctors do you get to spend an hour to an hour and a half with? And they have so much to cover, very important things to cover. But then if you remotely think that you have a bowel or bladder condition that you want to talk about more, come our way. We will talk your ears off about all of it. We want to know what's going on and figure out how to help. So we look at any belief systems or motivators or fears. You know, we're here to listen to you because it may be the first time you're actually talking about what's going on with your body. The assessment itself, this is what gets people. If you look online, there's a lot of information out there. I'm here to tell you that there are numerous ways to assess what's going on. So if you go see your urologist or you see your primary care and you get your prostate checked or you get your uterus checked for your exams, we are not like that. We test muscles. Yes, we can do internal work, but we can test a lot non-invasively too. So don't take away being fearful. You will read about it, but there's a lot of techniques we can do non-invasively too. I love this question. Tehegel or not Tehegel? How many people heard of this or are doing it? I know I did not. Yeah. It's not always correct Tehegel. And especially in multiple sclerosis, you actually might not, you may not want to be doing it. And we'll go over why in a little bit. But not everyone can figure out what's going on with your pelvic floor. So I describe it like a bicep curl. If we have weights and we lift them up, we start from the bottom, we lift them up, and we go back down. That's what our pelvic floor does. We contract, it lifts and pulls up, we let go, it comes back down. What if you're overactive and you're on all the time, and we don't know you're on all the time, and you're stuck here? Do you think you're going to efficiently close or pull, no, your muscles are going to be so tired because they've been holding so much weight all day long, they've been on all day long, they're not going to close very well. You're still going to leak. It makes a lot of sense when you kind of think about it. So it's not right for everyone. If you have spasticity in your bladder, you have a 90% chance that you have spasticity in your pelvic floor as well, in your urethral muscles. You should not be doing Kegels because you're just making it more overactive. You're making your bladder more irritated, and you're making it more stressful and difficult to go to the bathroom. So you really want to know what's going on and question, should I be doing this? Should I not be doing this? And if you even remotely question it, come our way. We'll help figure out, what exercises should you be doing and what would be helpful. So our team, we've grown. We've been here about 5 years. I'm really proud to say 5 years. And we've grown from one location with one therapist to multiple locations around the city with 8 therapists in 5 years. All because the word of pelvic floor is spreading out and people are talking about these issues and getting care. Very exciting. In women's health, just like physicians can specialize, you graduate med school, maybe you go into neurology, you can specialize in physical therapy as well. And we have 2 of 3 board certified men and women's health therapists at Ohio State, and there's only 3 in the state of Ohio and 2 are here. So that's really exciting about just the program that's here at Ohio State. There is one caveat. Not every pelvic floor therapist is certified to treat men. We are all certified to treat women, but there is extra training to treat men. So I've highlighted and starred which of our locations treat men, but if you're interested in an appointment, our schedulers are really, really good at weeding through where would be appropriate to go. So let's talk just a little bit about what's normal for your bladder. So, yes, I have a bladder. I gave this as a gift to the urologist I work with, and he wears it in his coat. So he got me one as well. Normal, when our bladder fills, and this is actually about the size of your bladder. It sits right behind. This is like legit the size that it normally should be when it's not super full. Crazy, right? When we're drinking or eating or exercising, our bladder's filling. Normally, if you think of a half a cup to 3/4 of a cup, our bladder should be aware that it's filling. It should be giving us some signals. Once we get to 1.5 to 2 cups full, we should probably go to the restroom. And our bladder should be telling, I'm going to hit this all the time. Our bladder should be telling our brain what's going on so that we can decide, do we want to go to the bathroom or do I need to hold it? I'm on a road trip. I can't pull over and I'm not using a rest stop. When we empty and we legit decide we want to go empty, because that's what's fun, like we usually have control and we decide when you potty train your children, you teach them how to go. Your bladder muscle contracts and your pelvic floor opens, and then the gates open and you get to go. With MS, there's a disruption to that system, and we'll go over that in detail. But normally we should urinate every 3 to 4 hours. And we should really not be waking up more than 1 time at night. If you're older than 75, 2 times at night is about even just because of your filtration rate of how your kidneys make urine at night. When you're older, that's typically more normal, okay? So this is just a little summary so you can see your pelvic floor is active in going to the bathroom. And then if you think of your MS and you think, where are my lesions? Your brain, your spinal cord, and your muscles all control going to the bathroom. If you have a lesion in one area, what's that affect? If you have a lesion in 2, holy moly, what's that do? Okay? These are what your muscles look like. You are all sitting on them right now. And if you've gone to the bathroom, you've all used them. And if you don't need to go to the bathroom, you're all using them right now anyways. So we just need to be aware of them. This is the difference between like male pelvic floor muscles versus female pelvic floor muscles. So you can tell they go from the front of our pubic bone to our tailbone, and they sit like a bowl underneath of us. There are specific muscles. There are 3 layers, okay? The second layer actually attaches with your urethral muscles and your urethra and your bladder. So you can kind of see the difference between male anatomy, female anatomy. We have pelvic floor muscles on both ends here, but the male urethra is really, really long. So has anyone ever had a sink that just keeps dripping and leaking and you need it fixed? If you're a man and you have dysfunction in this area, urine can keep collecting and then you're walking and then it's just like drip, drip, drip all day long because your urethra is like 15 times as long as ours. Women, we're not so lucky it happens sooner. Our urethra is really short and we have those muscles here around it. So 5 functions of our pelvic floor, just a brief overview. So they support us. You know, we get to walk, they support our organs and our abdomen. Sphincter, they keep us dry, they keep our sphincters closed, and they open them when we need to. Sexual function, blood flow, arousal, climax, all important things to be sexually active. Stability, when you walk, it helps keep your pelvic girdle. So every time I walk, my pelvic floor just stabilizes so I don't leak, and then my pelvic floor stabilizes so I don't leak. And then the sump pump, when we want to empty, we go empty. So I want you to leave here knowing how it functions, because if I ask someone, hey, what have you been doing for your bowel or bladder? They say, I'm doing Kegels, and then somehow they're moving and they're elevating out of the chair like Mary Poppins, and then it's not right. Okay, so your diaphragm sits here, and then your pelvic floor here. They work together. When you breathe in, the diaphragm comes down, the belly expands. Well, we don't want that pressure to come back up, or we're going to get reflux and nausea, and we don't want to vomit, right? So our pelvic floor relaxes to disperse it down. Then when we exhale, all of that comes back up. So when you do a Kegel, you should actually contract when you breathe out and train that. You sneeze, you cough, you pick up something, you move your walker, you get it in somewhere. You're breathing out when you do it. You want it to protect you. So a lot of us actually do this the opposite way that we should. I was very guilty of this. So what happens in MS? So I don't know how many of you have seen a urologist, but I'll touch on some diagnoses that typically not the neurologist, but the urologist will find. But throughout the first 6 years of diagnosis of multiple sclerosis, you will likely have a 75 to 85% chance of something happening with your bladder. That's a really big percent. So the earlier we see you, the longer we can off-hold more invasive intervention techniques. So the common complaints that we hear: urinary urgency, the Huggies commercial, I gotta go right now. The other commercials where you know where every bathroom is on every site and you want the blueprints to know exactly where they are. That's this. Urinary frequency, you go more than 8 times a day. I am guilty. I go like 4 sometimes, which is really bad as well. So you don't want to go too less, but you don't want to go too much either. Going at night, again, we talked about going more than once or twice at night. And then changes in your stream. Maybe it's hard to start your stream. Maybe your stream is weaker than it was, or maybe it has a mind of its own and it just sprays everywhere and we make a big mess. Maybe we think we're done. We get up, wash our hands, walk down the hallway, and we're wet and thinking, I just went to the bathroom. What is happening? Okay, maybe we didn't empty our bladder all the way. That urine that was left in there, we want to work on emptying mechanics. And then incontinence. You know, we laugh, sneeze, or cough or move, and we leak, or we feel we have to go and we have no time to get there. What's going on? So dependent upon where the lesions are can impact how severe those symptoms might be. And I like everyone to know the more severe your lower body symptoms, like your leg weakness or spasticity, the more severe your bladder symptoms typically are. And there are a lot of studies happening where falls are occurring in the home or in the hospital even, more or less. You're on your way to the bathroom most of the time. It's not that I was in PT and I was just walking down the hallway. I was getting to the bathroom. So one condition is the bladder muscle itself. So sometimes that input to the bladder is impaired, and your bladder doesn't like to stretch. It's very sensitive. Any stretch to it makes you want to go to the bathroom. So what do we typically do? We stop drinking water because then we don't fill our bladder and we won't leak. This creates a really, really bad problem where your bladder muscle does this all day long. That would not feel good. Okay, and you would probably leak and you'd feel like you have to go all the time. There are PT intervention, medical intervention, but this can happen. Okay, so that's the bladder muscle itself. And these usually happen if you have a lesion somewhere in the brainstem or brain. Another thing that can happen is maybe both the bladder muscle and your pelvic floor muscles aren't working. So my bladder muscle's going, all right, I gotta go. My pelvic floor is going, no, you're not. So what happens? You're not gonna empty. And then that could regurgitate back up and cause kidney disease or reflux, okay? So why do we care? We want you to sleep better. We don't want you paying money for pads. We don't want you feeling like you smell or that you can't leave your house. We want to protect your kidneys and protect the rest of your function because a lot of people who have a bladder dysfunction, maybe you have a UTI, it can make it seem like you have a relapse in your MS. They call it pseudo-relapse. Okay, but then the second you treat the bladder dysfunction, those symptoms die down and it actually wasn't a true exacerbation of the MS. That's how much this impacts you. All right, so in PT, these are just some of the things that we can do. A lot of the goals that we have or that I hear are, Steph, I don't want to wear Depends. If you have Medicaid or Medicare and they usually typically pay for your pads or Depends, they're not very effective. They're very, they don't collect a lot of volume. They irritate the skin, they're very thin, and most of the time you're spending more money because you're loading pads or towels or toilet paper. I have heard so many stories, and you're loading it in there to protect yourself. So a lot of this is what we hear. Conservative management, we're here to work with different components. If we need to have a bladder diary and see what is going on, how sensitive is your bladder, what's going in it, what's coming out, can we train your bladder how to fill and not be so sensitive? And if that happens, will it contract better to empty? A lot of times it does. It's just kind of a schedule that we do. I tell people not to jick. My patients crack up. I'm like, did you jick today? That is just in case voiding. You go just in case. How many people? Yeah, a lot of people do this. I just went a half hour ago. Oh, but I'm going to leave the house and I have a 10-minute drive. You should not have to go again. If you keep doing patterns like that, you keep making your bladder smaller and smaller and smaller until you're really sensitive and you're leaking before you can get to the bathroom. There's a lot of dietary management, fluid management, but we work a lot with pelvic floor muscle training. Now, key point, anyone who's seen a urologist, they like their scans. They scan you, then they tell you to go urinate, and they bring you back and they scan you again, and they like to see how much urine is left in your bladder. If you have less than 100 cc's left in your bladder, we are very successful at helping you. If you have more than 100 cc's in your bladder, we typically need both the urologist and us on your team longer term because it's dangerous when your volume's left in your bladder are here because then the bacteria builds, it can reflux back up into the kidneys. Okay, so this is what biofeedback looks like. You hear a lot about it if you even remotely type Google pelvic floor PT. This is non-invasive. We put electrodes on the outside of your muscles. You can stay dressed. We just put them where we need to. You can move around. And I can have you actually look at pictures or see or hear anything, and it mimics what your pelvic floor is doing because a lot of us just don't have that awareness of what are they, how do we work them, and how do we make it better. So this is really nice because we can figure out where you're leaking and then functionally train it specifically for you. There is some stimulation techniques. I don't know if anyone's ever had electrical stimulation. Sometimes your muscle just won't turn off. You do everything you can and it just stays on. Sometimes we need to fatigue it to the point to turn off, or maybe it's so weak it won't turn on and we need to help it turn on. You can use it for both, okay? And a lot of times we get you a unit for home So then you can do this at home and it'll stay with you throughout your lifespan. Okay, there are a lot of things I can teach you. I'm just going to kind of show you a few things, but we're going to skip here to bowels. I love this picture. It's from streets in Europe. They legit are named. These are the names of streets in Europe. You don't see this in America, and we should. Okay, basics of bowel health. You eat something, it's moving down through. The most important piece that you take away from here is in the morning when you eat your first meal, your nervous system is most stimulated and ready to digest and get your colon moving. When we eat, our stomach expands and fills, and it pushes down on our colon, causing something called our gastrocolonic reflex. That movement stimulates your colon to grip, stool, move it, okay, and brings it down to where we need it. And then our pelvic floor muscles, we train to then, once it's down there, let's controllably evacuate it, okay? You should be able to know the difference if you have gas, liquid, or stool. And I call this the elevator test. I ask all my patients, if you were in an elevator, could you hold it back or not? And if you can't hold it back, what would happen? You should know the difference. And if we don't, that can happen with the sensory input and the changes up the chain where our lesions are, knowing what's going on between our brain and the rest of our body and how they're working together. Okay, most common thing we see is constipation. How many people think they're constipated? I know I am because I didn't eat very well today. It can fluctuate, but the definition technically is if you go less than 3 times a week, but then on the times that you do go, if you feel you do not empty more than 25% of the time, you're likely constipated. So they added that second piece into it because of the work you might have to do, how long it takes, and if you're able to empty. So that's an important component to talk with your doctors about, because we usually just think, oh, I don't go enough. You got to empty too. All right? We can also look at incontinence of your bowel. It's terrible. This is what keeps people home. This is where people don't like to leave their house, when you lose control over your bowels. And I can tell you, sometimes it's urge related, typically in MS, where you feel you have to go and you almost lose mucus or stool before you get to the bathroom. We can fix that, usually pretty quickly, with just some education, dietary things, and tricks to make your muscles work the way they should. All right. So what do we do? This is what my patients look like on my table when I'm like, show me how you push to let gas go. And they're really self-conscious and they don't want something bad to happen. I'm like, I will cheer for you and do a dance if you fart, because that means everything went the way it was supposed to go and things are working and you consciously decided to do it. You were in control. A lot of times when you push like that, you're pushing down, your pelvic floor muscle closes because it can't sustain that much pressure. So you're basically just doing this. And nothing will come out. And you're on the toilet thinking, why won't it come out? I feel it down there, it won't come. So we teach you different techniques to be able to push and not strain, so that everything opens when it's supposed to and closes when it's supposed to. So I don't know if anyone's heard of the squatty potty. I like to say that it is legit a real thing. A doctor developed it, and some of the commercials on YouTube are hilarious, but very scientific to the eye on like why it works. So when sitting down, a lot of us think for fall risk, they give us toilet seat elevators because they raise us up and we don't want to fall and we're having trouble standing up. But if we don't actually fix going back to the posture we should be, you don't empty and stool gets caught back by your tailbone, back by your rectum, and you don't empty, and you might unfortunately empty that later whether you wanted to or not. So by putting your feet up on something, you change the angle so that to evacuate stool, you have a straight shot. Your muscles relax without you doing anything. Really nice, right? The second trick with this, let's say you think you're done, but you keep having to clean and clean and clean, and you're like, why am I still having to wipe myself? I just went to the bathroom. I call it smearing, because you haven't finished your bowel movement. Your muscles have not come back up and closed to finish what they're supposed to do. You can press out on the side of your legs. So if you're sitting on the toilet and you press out, if you try try that even in your seats sometime today. If you do that, you should feel like your rectum pushes down into the chair. Again, you're getting rid of what was left and stuck at the very bottom part of your anal canal. So those are just tips and tricks to help you. Okay? One thing that happens with bowel and bladder here, for bowel especially, if you think of the bottom of your rectum like a pipe, okay? If your pipe's really, really stretched out, everything can collect and collect and collect, and then we need Drano and we need to like move everything down through. Okay, that can happen with constipation. You've created this reservoir and your stool just keeps collecting and collecting and you're missing signals. I call it the call to poop. You should know when you need to go to the bathroom, but if your rectum is a mega rectum and it's super stretched out, you're not gonna get it till like maybe your belly hurts or you feel nauseous or you're so bloated that your pants aren't fitting correctly anymore. Okay? Now, if you have the opposite problem and your rectum and your pipe is super thin, well, number one, if you have big stool, it's not coming out. So then you have snake-like stool that's really hard to empty because it gets cut off and then we're frustrated and we're cleaning and cleaning and cleaning. This happens a lot with MS. Everything gets spastic, everything tightens up, and we don't have good passage. So in PT, we work on exercises to either make you wider if you need to, or make you smaller so that you're getting that right sensation for your bowel control. All right, so these are just some things that you might feel. And then I love, love, love my stool chart. I don't know how many doctors pull this out. Mine is laminated, it's really fancy, and if I could have a poster, I would totally have one. You want your stool to look like this type 4. So if you went to the bathroom this morning, what'd you look like? My patients call it, what's your poop number? And they want like buttons on when they get type 4. Okay, so this helps things manage down further. We can do that through diet. We can do that through massage techniques. We can help you get there. So back to Kate, my wrap up here. So Kate saw me for about 6 sessions across 3 months. Okay. We did flaxseed meal, which is a type of fiber that all she did was put it in her food. She did a belly massage at night, and she got a squatty potty, and she started walking. Her balance was improving. She ended up having 1 bowel movement every other day. So 1 bowel movement a week to every other day. Pretty good. We did a lot of down training. Kate did no Kegels for me. Kegels would have made her worse. But who would have known to tell her? Okay, with a bladder diary and training your bladder and how to fill and how to empty and how can we modify that through exercise or diet or water intake, she ended up only wearing 1 pad a day, and that pad was really just a safety net for her. She wasn't leaking much anymore. It was just she had it just in case because she didn't believe that, oh, I don't need this. So give it time. It takes some confidence. I encourage my patients, if you even remotely try it, wear nothing around your house. Go commando. See what happens. And then maybe wear it in public and give yourself that confidence. Because if you get anxious and you feel like something bad's going to happen, you input that to your nervous system and your muscles do this. So it's a mind over body type of experience that we want to gauge, okay? So we have some questionnaires that your doctors might give you, and then they can go on how to refer to us. But this is my information that you all will have. Feel free to email me if you just want to call and discuss anything. I am very happy to help, as will anyone else on our medical team. Okay? Thank you.